So in this, we'll be talking about not only the seeing eyes, but the eyes which are totally blind for the functional reasons. So we sometimes tend to ignore those eyes, but no, we should not be ignoring them. There could be these type of eyes. We'll be counting them once in a while. So this is not the defeat of ophthalmology, that if you can't provide a good visual acuity or rehabilitate the person with vision, it's not only the vision, but if in case vision of course is very important, but in case there is a condition where you can't do anything about the vision, at least you should be taking the challenge and accepting to give a very good cosmetic appearance to the patient. The procedures sometimes which we need is doing enucleation or evisceration before giving a custom made prosthesis, or we call it as COMPM. Okay, custom made prosthesis. And this is these are the indications which we come across in which we do these type of procedures. Like it could be a blind eye, which could be because of chronically painful blind eye, objectionable appearance in which there is a corneal opacity, staphylomas, anterior staphylomas, ciliary staphylomas, or ophthalmos, as in glaucoma session it was being told. Sometimes intraocular tumors, atrophic bulbi, and severe microphthalmos. So these type of eyes which are blind per se, but they need rehabilitation. And even sometimes these are seeing eyes, like an intraocular tumor which is intractable, or we can't do anything about it. We need to enucleate, and to prevent sympathetic ophthalmias in cases of traumatic or other reasons. So sometimes we need to resort to these conditions and these surgeries. The aim is to provide good cosmesis to maximize patient comfort, to protect vision of the fellow eye in case of sympathetic ophthalmia, and to safeguard life and to improve quality of residual life, especially in cases of malignancies. So this is initially was a barbaric procedure in which they used to have crude tools, but now there is a lot of advancement in the surgical technique. The standard surgical technique for the enucleation is a 360-degree peritomy with a subtenon dissection, hooking the muscles individually and tucking them and fixating them, then disinserting the muscles. This is mainly the tips for the intraocular tumors like retinoblastomas and melanomas. Then you keep the muscles intact, and then disinsert the muscles, but keep them handy, and you bring the muscles on the respective fornices. You tuck the disinserted end and pull the eyeball out of the socket. Sometimes you need to do canthotomy and cantholysis, as Dr. Manu Saini showed in one of the videos. That will lead to a good space and the eyeball can be easily popped out. And then you try to reach from the lateral aspect into the posterior compartment of the orbit. Try to make a single snip with the optic nerve. This is especially important if you're dealing with conditions which can be transmitted through the optic nerve, like in retinoblastomas, and where you are suspecting optic nerve extension of the retinoblastoma tumors. You would have to have a good length of the optic nerve which is dissected, so there is no socket extension post surgery. Earlier it was suggested that you use a clamp before you cut, but it's really difficult practically to put two instruments in, so a single snip would be good enough. There's no need to crush after the cutting. There is of course a gush of blood. You can do a good hemostasis by doing a pressure technique, which is very helpful and takes care of the thing. So after removing the eyeball completely, you assess the eyeball and see for any extraocular spread of the tumor, as in this case, and you examine the stump of the optic nerve, measure it, write it down as a documentation, see the sheath over the optic nerve, whether it's free or fixed. In case of fixed sheath over the optic nerve, that suggests that probably the sheath has also been involved and there's an optic nerve invasion. Then you place a appropriate sized implant, which I'll be discussing, in the posterior orbital compartment, and you can tie the muscles over the implant, which was earlier done, but now these muscles are brought to the respective fornices and you cover them with tenons and then with the conjunctiva. That gives a better motility to the socket and also reduces the chances of migration of the implant. Of course, you put the conformer after the surgery, which is shown in the last slide, which is very important. So that is important to maintain the socket size, and of course that will be replaced by the prosthesis later. The socket hygiene needs to be maintained, and the prosthesis can be given after 4 to 6 weeks of surgery once the socket is no more inflamed and the edema has subsided. So discussing on what type of implants we have and what is the appropriate size, I'll rush on to the categories, but you should all know, because these could be a viva questions, even a practical. They can show you implants and ask you what type of implants they are showing. Implants can be categorized into non-integrated, semi-integrated, integrated, bio-integrated, and biogenic types. These are the non-integrated ones, where you have the PMMA ones or the silicon ones which do not integrate, but also we have the hydroxyapatite, which is integrated implant, but it is rough in surface, and this is a biological implant, which is was the DFG, which is dermis fat graft. Now, what is the size of the implant? What is the appropriate size? As we know that the globe size is about 7 cc of volume, and once you enucleate, you are left with that void in the orbit. So you have to fill approximately 4.5 cc with the implant, and 2.5 cc is left for the prosthesis to fill in up. So this 4.5 cc is generally, you can decide by doing an intra-operative sizers. There are sizers available, which is just like PMMA implants with the handling equipment. So there's a handle to it. You can place one by one and see which is the appropriate size, or you can determine by doing an ultrasonography of the other eye and see what is the axial length. Approximately axial length of the other eye minus 2 millimeter should be fitting in. These are the normograms for the enucleations. In case you're doing eviscerations, then you deduct another 2 millimeters, because that doesn't fit and the scleral cup is there. Sometimes you need a relaxing incision in the scleral cup. Where to place the implant is again important. Place it posterior to the posterior tenons, because you need the tenons. Capsule is a very important, the sturdy material. It has to cover the implant so that there is no extrusion of the implant. The muscle cone, you have to place the implant within the muscle cone and within the scleral cup in cases of eviscerated eyes. Even if the scleral cup is small, you can do a posterior relaxing incision 360 degree, or you can give circumferential cuts to fit in the good appropriate size of the implant. But your plan is to put within the scleral cup. Why? Because the scleral cup has muscle insertions, and that will lead to the movement of the socket and to the prosthesis, which is very, very important post-operatively. So these are few pictures showing what type of eye was there, where you have placed the implant, and once the implant is placed, this cap-like thing is the prosthesis later on. In cases of rough implants like hydroxyapatite, you need to cover the implant before you place in there. There are various materials available which you can use. Now, once the surgery is done, once the post-operative period is fine, there are various ocular prostheses. One could be stock eyes, customized prostheses, and custom prostheses with pegging. These are important ones. The last one is now obsolete, generally not done. Stock eyes is like ready-made eyes, which are very cheap, easily available in the market, can be fitted in a very short time. You have a gamut of a box of artificial eyes you select, and you just keep on trying whichever fits the best, you give it. It does not require trained ocularist, but these are not very well-fitting eyes, and these are generally a poor quality, which may lead to the socket syndromes, and the socket in coming years may get inflamed and get socket contraction. They're not very well cosmetically tolerated. And they also have a disadvantage of chronic discharge, discomfort, poor matching, less movements, restricted wearing periods. You have to remove the eyes every day. Lower lid sagging, contracted sockets and whatnot. The chipping can be there. They can be breaking, and the edges become, chipped off, which gives irritation and constant inflammation to the socket. Technique for custom prosthesis is you take the implant size of the socket by putting an impression conformer. Then you take the size of the socket, and then you prepare a mold, which is then converted into an acrylic, initially the wax mold, then you convert it into the acrylic mold. Then you take the centration of the socket, you paint the iris button, you fit and see the centration of the iris button. Then you cover up with a transparent acrylic layers, and you fit in the eye, and you see such a wonderful cosmetically rehabilitated patient with a wonderful post custom prosthesis movements. Movements are pretty good. Patient can keep the eyes on even while sleeping, bathing and all not whatnot. So these are few results, very gratifying results. This child was not ready to go to school because of her bad looks, but after giving prosthesis, she studied well. Similarly, in another child, after thiatrical eyes, you can straight away go in for prosthesis. But in this case, it was a staphylomatous eye which was eviscerated. This is the post eviscerated socket here, which after the prosthesis you look like this. So if you even you enlarge the view and you see, hardly you can make out which is the good eye and the bad eye. Sometimes you are unfortunate enough that you can't salvage even a single eye, and both the eyes were enucleated for this chap, and it was very difficult for the parents to carry the child. So both of these are the custom made prostheses. Of course the child can't see, but still the parents can carry it well. So if the child loses the eye in early childhood, then there could be various complications. You have to address the complication as well. The conclusion is, it is a cosmetic procedure. It is not a destructive procedure. In most of the institutes and the organization, it is treated as a destructive procedure. It is given to the junior most person of the group, which should not be the case, I believe. And this is the first surgery most of you would be doing it, but do it in a nice way and show your skills there itself. It is not a destructive procedure, it is a cosmetic procedure. Do the enucleation or evisceration very well, put an implant wherever possible. There's a whole complete topic whether you put a primary implant or secondary implant. I'm a proponent of putting a primary implant. That means even if you have an infective condition like endophthalmitis or panophthalmitis, try putting in an implant. Even if there's a 50% extrusion, you still have 50% patients who have a good implant therein. Because if you go in for a secondary implant, 90% of the time you're not able to put a good implant in the secondary case, and the half of the time patients won't come up once their symptoms are gone. Choose a proper technique, choose a correct implant, a correct implant size, a correct implant material. Of course, give a custom prosthesis rather than giving a ready-made prosthesis. But if you have nothing, then of course give a ready-made prosthesis at least. Do not shirk from doing a conformer. Conformer has to be placed. You generally have a very gratifying results. Believe me, and patient will always thank you. Few of the slides were taken from my mentor. I acknowledge them. My holy city, Amritsar, where I belong to, and I do practice in Chandigarh as well. Thank you very much for your patient layering and staying till the end. This is my number in case any PG wants to have any connections with me regarding any questions for oculoplasty or whatever they have their questions. You can always be here. I really thank Dr. Suresh, who is very much enthusiastic in your learning. I believe you should, believe in his teaching and encourage him by being present here more often and learning a lot from these type of sessions. He puts in a lot of efforts in these sessions. I really praise you, Dr. Suresh. Thank you very much for having us all here.